Hi everyone, thanks for joining us for our latest edition of Phoenix Children's Live. I'm Stacy Dillier, one of the brand managers here at Phoenix Children's, and today I am joined by Dr. Singh. She is the division chief for our division of plastic surgery, and today we are going to be talking about cleft lip and palate. If you have any questions along the way, just leave them in the comment section and we'll be sure to get them asked and answered. And if you have any questions after the live stream is over, just leave them in the comment section and we'll get them over to Dr. Singh. Thank you for joining us today. It's great to have you. So we'll just go ahead and jump right in. Tell us just briefly about yourself, what brought you to Phoenix Children's. I know you've been in the Valley for a few years now, quite a few years. So just tell us about yourself and what brought you here.
Well, thank you for having me, Stacy. It's a privilege to be able to communicate with our patients and families through Facebook. Definitely not in my generation of communication, but it's a great opportunity. I've been in Phoenix now for 12 years, and really my passion is taking care of pediatric patients. Built a great practice primarily with children with diagnoses of cleft lip and palate and craniosynostosis. And my dream, always having worked at PCH over the past 12 years, is to build a comprehensive division of plastic surgery here and to really bring everything under one roof so that we have a home for our children here, so that all of their plastic surgery needs could be met here.
Perfect. It's definitely needed, so happy to have the division here at Phoenix Children's. All right, how common is cleft lip and palate? And well, first we should start off with what is cleft lip and palate, and then how common is it?
So cleft lip and palate, and you can have cleft lip in isolation, or it can be with the cleft palate involve the gum line as well. It's relatively common. 1 in 500 to 600 children are born with cleft lip and or palate.
Okay.
Most of the children, when they have the diagnoses, have cleft lip and palate, but it can be in all varying forms. You can have an incomplete cleft lip or a complete cleft lip, and it also affects the nose. It causes the septum, which is the middle of the nose, to be shifted. It causes the tip to be collapsed. So it's just not just the lip that is affected, but also the nose. And then the gum line, where the teeth come out, can be affected, as well as the palate. And we really don't know until the child is born how to classify or describe the actual cleft.
Okay, but can it be diagnosed in utero?
Yes.
Okay.
And probably about 85 to 90% of our babies now receive an in utero diagnosis.
Oh, wow.
And it can really be seen clearly on week 18 or 20 ultrasound. It's the level 2 ultrasound. And if at that ultrasound there's some suspicion or concern of a cleft lip and or palate, then further detailed ultrasounds are done. A fetal MRI can also be done, which further delineates the anatomy.
Okay.
So the cleft palate is hard to visualize on ultrasound, but on fetal MRI, one can clearly see if the palate is involved or not. And so we meet with the families during this consultation while mom is still pregnant with a baby, and it gives us a great opportunity to educate our families, to get to know them, to start a lifelong journey, because we do see our babies with cleft lip and palate from birth until they're age 18, 19 years of age.
Oh, wow, that's great. I imagine it's definitely comforting for the families to be able to meet with you before their child is even born and sort of figure out what their journey looks like. So that's great. How is it genetic? So can it be passed down from a parent to a child, and or if one child has it in the family, is another child more likely to get it?
Yes, so if a parent has it and it's associated with a syndrome, and only 15 to 20% of children with cleft lip and palate have associated syndromes, and some of the more common ones are Stickler syndrome, van der Waals syndrome, 22q, 11.2 deletion. Only 15 to 20% of children actually have those syndromes. Then the likelihood of it being inherited or genetic is much higher.
Okay.
It's 50%.
Wow.
Whereas when it's spontaneous, which is the vast majority of cleft lip and palate, the inheritance risk is less.
Okay.
And we always tell parents, even though we have great genetics colleagues here at Phoenix Children's Hospital that can probably provide more detail than I can, we guide families that if there is a close first-degree relative involved with a cleft lip or palate, the baby, instead of having a 1 in 600 chance of having cleft lip or palate, has a 2 to 5% chance.
Okay.
So a little bit higher. If your first child has it, then the second child having it, the risk is a little bit higher than that.
Okay.
It jumps to about 7%.
Okay. Wow. And do we know what causes it? So if it's not tied to one of those other diagnoses, do we know what causes it, or is it just kind of happen?
Most of them are just spontaneous, what we
Okay.
call spontaneous mutations that cause the cleft lip and palate to happen, but there are some environmental factors which have been identified, and alcohol, medications, prescription medications for epilepsy and acne, like the retinoids, are known to be environmental sources of causing this. And it's really how these environmental factors interact with genetic factors that causes the cleft lip and palate. We do know that the cleft lip or the lip and the nose and the palate form in the first trimester between weeks 7 and 11.
Oh, wow.
And oftentimes moms are not even aware that they're pregnant at that time. So sometimes there are environmental factors that come into play.
Okay, that's good to know. And we already talked about the different classifications and the different types. Is one type more common than another, or is there one that you see most often? Or?
So the vast majority of when the cleft involves the lip and the palate are on the left side.
Okay.
So the left-sided cleft lip and palate is much more common than the right side, and more common than bilateral cleft lip and palate, where both sides can be involved. The cleft lip and palate diagnosis is also more common in boys than in girls.
Oh, wow.
And no one really understands why that is.
That's really interesting. Okay, so I'm assuming you have more
Male
patients
patients
than you do
Yep.
female patients. Okay, that's good to know. Is there any reason for that, or you just...
No one's been able to identify
Okay.
the source of that variation in gender.
Okay. Wow. All right. Looks like we had a question come in. What advice do you have once we are past the first surgery? My son had his lip and palate repaired. What can we do to prepare for the next wave of surgeries?
So is it the lip and the nose that was repaired, or the lip and the palate?
Let's find out.
So generally, just timeline of surgery, the lip and nasal repair is done usually around 4 months of age.
Okay.
Sometimes if there are other conditions that are affecting the child, such as a heart condition, then we do delay the surgery. We have to prioritize the heart condition ahead of time in terms of if there's any surgery that's needed. And then the palate repair is generally done between 12 to 13 months of age.
Okay.
In the literature, it says you can do it anywhere up to 18 months of age without having any long-term negative effect on speech.
Okay. All right. And it looks like it was both. All of it, he or she said. So.
Okay. So if the lip and nasal region and the palate surgery have been completed, the next surgery that we're really looking at doing that's planned is repairing the gum line, and that's called the bone graft surgery, where we take some bone marrow out of the hip bone to put into the gum line so that the adult teeth can come in a normal fashion.
Okay.
In that interval, and that's around 7 years of age,
Okay.
in that interval around 3 to 4 years of age, what we're really looking at, the next milestone is speech and language development.
Okay.
Language is a cognitive aspect of a child's development, and that's not impaired. It's really the speech quality, which is the sound of one's voice, and that's where the palate has an impact.
Okay.
And if the palate doesn't move as well because of the cleft and the surgery, or if it's not long enough, oftentimes children can have a speech that has a nasal quality to it.
Okay.
A little bit of nasality, you can still understand the speech, but if the nasality is more significant, it's very hard to understand the child's speech. And we begin assessment. We try speech therapy first. If speech therapy is not effective in strengthening the muscles, we then look at what we call secondary palatal surgery.
Okay.
So I hope that answers the question.
Okay, great. Thank you. So how many surgeries is a child looking at potentially when they have either a cleft lip or both, cleft lip and palate?
When we meet with families during the in utero consultation, we say to them, we're going to talk to you about 3 definite surgeries.
Okay.
The first surgery is the lip and nasal repair, which is done at around 4 months of age.
Okay.
The second surgery is the palate repair, which is done around 9 to 10 months of age. And then the third surgery is the bone grafting surgery, which is done at 7 years of age.
Okay.
And then along the spectrum comes the individualized need of the child. If there's any speech surgery that's needed, then that surgery is done between 4 to 6 years of age.
Okay.
If there is any surgery needed for revision, one item I forgot to mention is that cleft lip and palate, it's not the same in each child. It comes in varying degrees of severity with asymmetry. And so some children have milder forms and the growth pattern is more favorable. In those children, they never need a revision.
Okay.
Other children who have wider clefts and more affected clefts where the bone is more affected and there's more missing tissue, their surgical need is greater.
Okay.
And we have to do it in a staged manner for reconstruction because of the age and the growth potential in the children.
Okay. So is that potentially when you see them until they're 18 or 19?
Correct.
Or so? Okay.
So regardless of the severity of the cleft, my practice is to follow my patients until they're 18 years of age, and then I graduate them from my clinic.
Okay.
Now, some children are not done growing at 18. Some boys grow until they're 19, 20, 21, in which case I continue to follow them. And the last thing we're really looking at in those teenage years is the growth of the jaw.
Okay.
Because the cleft palate affects the bone, oftentimes the upper jaw does not grow at the pace of the lower jaw, and children need to have jaw surgery done to correct their bite.
Okay.
And then they may need some revision of the lip and nasal region once the jaw has moved forward. And so those are those last few surgeries that are done between ages 16 to 21,
Okay.
depending on the completion of growth.
Okay. And so after they have, say they only need those 3 surgeries, they have their first 3 and they're 7 or 8, do they come for annual visits? What does that process look like to follow the jaw and all of the other structure growth?
So if we're in a good functional aspect in their life at around age 7 or 8, speech is good, aesthetics are good, the bone graft has been done and has healed well, and they're in what we call phase 1 orthodontic treatment, then I do monitor them just once a year, once every other year.
Okay.
And we do this through our Barrow Cleft and Craniofacial team.
Okay.
And this is a great team of different specialties that we have. And so our orthodontists on the team are the same orthodontists who help us with molding the lip and nose prior to the cleft lip repair. Same orthodontist they have when they start their braces at age 7 or 8, the same orthodontist they have at age 16, 17. And so there's great continuity of care for our families and for our patients. We also have speech and feeding therapists with our team, and all they do really is to treat babies and patients with cleft lip and palate. So they're very, very specialized, and they help us all along the way, first with feeding concerns in the newborn period, to transitioning them to solids, and then evaluating and treating speech conditions.
Okay. Wow, that's great. And other than the potential speech delay, is there any other delays that a child may have, or?
Sometimes not sometimes, whenever the gum line and the palate are involved, the teeth are always to some extent involved at the cleft site.
Okay.
And we have pediatric dentists on our team also who specialize in children with this condition. And it's really knowing, okay, which teeth should we preserve, which teeth should we pull, how should we maintain hygiene of these teeth, and at which point do we need to intervene. I would say that almost 100% of our children who have the gum line involved and the palate involved need to have orthodontic treatment.
Okay.
And so that's another component which we prepare families for early on.
Okay, that's great. Let's see. Do children born with cleft lip and palate have any issues being fed?
Yes.
I imagine that was
yes.
the answer.
That is the biggest concern. And when we do our in utero consultations, which our PCH Fetal Care Network is wonderful about organizing and really making it seamless for families. We try as plastic craniofacial surgeons to see our moms the same day that our speech and feeding specialists see them, the same day as our psychologist, and the same day as our orthodontist. So they have an appointment with 4 different specialties, and these are the core specialists who care for their children, even though we have 15 other specialties, if they're needed, can be involved in the child's care. And so these kids really, the number one concern is feeding, right? You have a newborn. What do all moms and dads worry about? How am I going to get this baby to gain weight? And I think that the in utero consultation is most important from a feeding aspect. We explain to parents that if the palate is involved, that the baby's not going to be able to have typical suction that's needed to feed from a regular bottle. Okay. And so there are adapted cleft feeding bottles, and our most liked and popular bottle right now is the Dr. Brown's cleft adapted bottle. Okay. And I'd say 90 to 95% of our families where the baby needs it use those bottles. It's very easy for families to use. There are 2 other different feeders. Nursing is challenging because it requires suction, mm-hmm. and so we try to prepare moms for that because that's oftentimes hard if the goal really was to be able to nurse the baby. Yeah. And bonding, nursing for bonding purposes is promoted. Mm-hmm. Just for nutritional purposes it's challenging.
Okay, that's good to know. Thank you. Is surgery? I'm imagining surgery is the only option to correct the cleft lip and palate. Mm-hmm. Okay.
Yes, so all children need to undergo surgery to repair the cleft lip and palate, but our orthodontic team at the Barrow Craniofacial Center is amazing in what they can do with just molding the lip and the nose to get a more ideal anatomical structure and shape before we do surgery, and that makes our success rate in terms of the outcomes of surgery much stronger, and it decreases the number of revisions of the lip and nose that are needed. Okay. And we've been doing that now for 13 years here. It's been happening across the country for 20 years.
Oh, wow.
And we've found that as our children grow, their growth pattern is more favorable if they've had the nasal molding and stenting. And it's a non-painful procedure. It's just what we consider orthodontics for babies, and it's just done with taping and very soft stents.
Okay. And what does the surgery process look like? I imagine, if they're having 2 surgeries before they're a year old, do they have to stay overnight after the surgeries? And then what does that feeding process look like for a child who's just had surgery?
So before any anesthetic, they're not able to feed the baby for a certain number of hours, mm-hmm. just to make the anesthesia safe. But after both surgeries, we allow feeding immediately. Okay. In the recovery room. Most of our babies who undergo cleft lip surgery are able to go home on the same day, and they tend to feed well because the bottle contact is mostly inside the mouth, mm-hmm. and they are able to bypass the lip repair. After the palate repair, it's a little bit harder. And so we prepare our families that the recovery is generally a little slower than after the lip repair. It's a more sensitive area of the mouth, more contact with the bottle. Babies older, more aware. Mm-hmm. And we do keep our babies overnight after the palate repair. Probably 75 to 80% of them stay just one night and go home the next day. Okay. But then another 20% end up needing 2 nights in the hospital. And our criteria for letting the families go home is when the baby's feeding comfortably. Okay. So we don't want the babies to go home and get dehydrated.
Okay. And you'll have all the families calling you, right. Asking questions. Right. I know you said males are more likely to get it than females, but is there a certain ethnicity that you see more often than not with cleft lip or palate?
Yes, so all of the literature shows that the Asian population has the highest incidence of cleft lip and palate, but then after that, Native American and Latin mix. Okay. And so we have a high proportion of those ethnic mixes in the Phoenix area, and so our volume of patients we see is probably one of the highest in the country through our Barrow Cleft and Craniofacial Center.
Wow, that's really interesting. All right, let's see. We already talked about that one. Okay, next question. What does our program look like? I know we obviously treat cleft lip and palate here. Tell us about the Division of Plastic Surgery and what the team looks like.
Sure. So I've been working with our Barrow Cleft and Craniofacial program ever since I arrived in town. It's been in place for 30 years, and we've always done our patient surgeries here at Phoenix Children's Hospital. Our co-medical directors for our Barrow Cleft and Craniofacial program are Dr. Stephen Beals and Dr. Patricia Glick. And it's really without our team format, we know that a team format is the optimal way to take care of kids with cleft lip and palate. Where our division comes into play is that we're building a division here and working in close contact and close involvement with the Barrow Cleft and Craniofacial program to team our children. We recruited Dr. Tom Sitzman in June of this year, and he not only has specialized training in cleft lip and palate, but also has an NIH grant looking at outcomes in cleft lip and palate. Oh, wow. And it's a very robust study which will give us a lot of information on how we can improve surgeries and procedures for patients.
Okay, that's great. So I know you mentioned Barrow Cleft Lip and Palate, correct?
Right.
Do all of the patients have their appointments here, or do they have to go off-site, say, for the orthodontics and the dentist, or do they come here for that?
So they have their appointments with us here, and then the Barrow Cleft and Craniofacial Center is just down the street, okay. Based at BNI, okay. And it's historically is where it's been, and it's a fantastic facility where they can see most of the other providers in that one okay. area. And in the near future, we're hoping, Dr. Sitzman and I are, to be able to go over there to hold clinics so that the patients don't have to travel back and forth and have it be a satellite of sorts for PCH.
That's great, but you're right, it's not that far, right down the road from here.
And we're able to effectively coordinate appointments on the same day, so it works out really well for families.
That's great. And I know you mentioned a few different areas of the hospital that are involved, but just outline for us again what the multidisciplinary approach of this clinic looks like.
So we know that providing multidisciplinary, or what we call interdisciplinary team approach is very effective in making sure the children have the best outcome, and we really work together in a coordinated manner. We're in constant communication with our colleagues who are involved in the child's care, and it's also been convenient. ENT, since they joined, PCH is on the same floor as we are in our office building, and ENT sees a number of these children in dealing with their middle ear fluid and middle ear infections, and there's a higher rate of that in children with cleft palate because of the eustachian tube dysfunction. So when these patients come to see me for their cleft lip and palate treatment, we can coordinate these appointments with ENT so that they're taking care of evaluating their ears. And so that is something on site, and I think having our ENT colleagues nearby has really been, for patients, a big positive in coordinating appointments instead of really running all over town. So
that's great. Lots of great new surgical practices that we've added over the past year that are really beneficial to patients. How do patients make an appointment? So obviously they're diagnosed in utero. Tell us a little bit more. You mentioned Arizona Fetal Care Network. So what does that process look like from families from when they find out that their child has cleft lip and palate to when you get involved?
So there are a couple of different routes. Some families, parents obviously all speak with one another, and when they get a diagnosis of a cleft lip and palate, the natural thing is to go online and connect through social media with other families or friends who also have a child with cleft lip and palate. So some of our calls come via that route, where families will call and they'll say, we had an ultrasound, we have diagnosis, one of our friends is so-and-so whose child you took care of, and we'd like to make an appointment. And so they just call our office directly and we meet with them. Some of our other referrals come through the Arizona Fetal Care Network, and Jessica Feltz and Gretchen, who are in charge of that, really do a great job of coordinating all of the appointments. And I think that care coordination is really what is helpful for us as providers to communicate with one another, but also for the families, so that that element of work is taken care of.
I can only imagine when you're going to have a baby, you have so many other things to worry about. So to not have to worry about
setting up the nursery,
to not have to worry about that part of it is huge for them.
I think that we know in healthcare the care coordination piece is so critical, especially in our children who need multiple different specialties involved.
Okay, that's great. On the off chance that a child isn't diagnosed in utero, how does that process look like? Do they then find you after their child is born? Are they referred from whatever hospital?
Generally the hospital will call us, and I have privileges at a number of different NICUs across the valley. Primarily, even though I work here at PCH, if one of my babies I've seen in utero even is born at a hospital and is having difficulty with feeding or any concerns related to the cleft lip and palate, I can go to the NICU and visit the family and see them. And it's the same thing if there are newborns across the valley, and if they're having challenges with feeding, we're certainly a resource. Our Craniofacial Center and our feeding therapists are happy to be involved and help with the feeding component. I also oftentimes go and communicate with a neonatologist. So generally it originates from the hospital.
Okay.
Most families, that gets taken care of, but if for some reason it doesn't, they can always reach out to us through our office line.
Okay, that's great. Thank you. What other resources, are there other resources out there for families who have children with cleft lip and palate? I know you mentioned social media. I'm sure that's a great point for families to come together, but is there any others out there that you know of?
Yeah, so I always send my families to the American Cleft Palate Craniofacial Association website.
Okay.
There's a great component to that website that's designed for families and education, and there are pamphlets both in English and in Spanish about every component, about the genetics of cleft lip and palate, the feeding concerns, the aesthetic concerns, the psychology of it, the surgical components. I'd say there's probably about 40 to 50 educational pamphlets, and those can just be printed out online if the families desire. There are a lot of other websites that are not kind of organized by our national associations, which families get some information from, but not having vetted the information on the website, it's hard to know or to recommend. But I think that oftentimes our parents' greatest resource is one another. And so I really, we have a number of what we call family liaisons who are willing to speak with other families who have a new diagnosis so that they can kind of see it from a parent's perspective as opposed to seeing it from a provider's perspective.
I'm sure that helps reassure them too, that hey, my child went through it, yours is going to come out on the other side too. Right. That's great.
It's getting through the process that is the challenge of it, and we as providers know that these kids are going to end up doing really well, and they're going to be great, productive citizens. But I think for parents, it's a hard journey.
Yes, definitely. All right. We had another question come in, so thank you. What is palate expansion surgery?
So palatal expansion is generally, hopefully not done surgically. It's done orthodontically, and we know that when a child has a cleft palate, and I'm just going to use my hands as diagrams, that this is one segment, this is one segment, and the cleft is running in the middle, and there's bone missing. So what generally happens over time after the repairs occur is that the cleft narrows, which is good because you don't want a large gap where the teeth are going to be coming out, so that it collapses. But that palate now is narrow, and before we do the bone graft surgery, our orthodontist put in a palatal expander, and it's just anchored to the molar teeth, and you have to turn it slowly each day, and it expands the palate back to where it should be, and then the gap is filled with bone. And then once that bone heals, that device is removed and the palate is maintained in its new width, which matches the lower teeth. Because our teeth should fit together very, very much like an envelope and in a tight, kind of a tight fit with the teeth. And so that's where we decide, okay, how much does it need to be expanded? How much, in terms of whether it's 3 millimeters versus 10 millimeters.
Gotcha. I'm pretty sure anybody who needs orthodontics could have one of those. I'm pretty sure I had one when I was a teenager.
a lot of people have
I remember the cranking of that expander.
So a lot of people, a lot of kids, even without having a cleft lip and palate, undergo palatal expansion. It's a very common orthodontic, procedure that's done.
And it's not as painful as it sounds, I promise.
Okay. I didn't have it done, so I'll trust you.
All right. Is there anything else that we didn't touch on today that you wanted to talk about, or?
I think that, Stacy, you covered pretty much everything. We are going to be expanding our division. Currently, there's just 2 of us, but we're hoping in the next year to add on 2 more providers. And we really look forward to building a division here and to for the support of PCH in building this. And we're excited to be here.
We're really glad to have you. Thanks for joining us.
Thank you, Susan.
If you have any other questions, leave them in the comments and we'll get them over to Dr. Singh. Thanks for joining us, and be sure to tune in next week for our next edition of Phoenix Children's Live.